You know, most people see me in the operating room or in the clinic. What you almost never see is this. Me, early in the morning, with a hip and knee journal and a pen in my hand, perfectly happy. I'm Dr. Tyler Goldberg, orthopedic surgeon specializing in concierge hip and knee replacement. And for the last 25 years and 12,000 surgeries, I've seen patients literally transform physically and mentally. And I'm on a mission to transform the way the world experiences joint replacements. Ready? Let's hit it. Let me give you a little background about me. What patients don't really know about me is that I'm addicted to orthopedic literature. If hip and knee replacement didn't exist, I honestly don't know what I'd do. I don't think I'd be a doctor even. General medicine, not for me. Hormones, no thank you. Parts, none of that ever really lit me up. I knew I loved surgery, but not soft tissue surgery. I like bones. I like structure. I like angles. I like mechanics. That pretty much pushed me straight into orthopedics. Well, within orthopedics, I started crossing things off the list. I don't like spine. Hand patients, way too complicated. Shoulder patients, way too much rehab. Fracture work, those patients come in at 2 o'clock in the morning. Hard pass for me. Feet, I hate feet. So what's left? Well, it's hip and knee replacement. And that, for me, is where everything clicked. I'm endlessly captivated by it. I could read about hips and knees all day, every day, never get bored. I could have the same conversation with patients all day, every day, and never get bored. I do the same 2 operations all day, every day, and guess what? Never get bored. So you might be thinking, okay, that's nice, but why do I care how much you like journals? Well, it's because hip and knee replacement is not a static field. Implants change, materials change, techniques change. Some of those changes are genuinely better. Some are just marketing them. My job, if I'm going to be your surgeon, is to stay obsessed enough with the data that I can sort of tell the difference. And that's what this is, me doing homework on behalf of your hips and your knees. So let me show you how I actually read one of these. First thing you can see, no distractions. I usually do this early in the morning, sometimes before clinic, sometimes on a Saturday morning when my mind is clear. There's no TV, there's no phone, there's no email popping up every 3 or 4 seconds. I've got an active pen in my hand the entire time. I don't passively scroll through. I mark, I circle, I write questions in the margins. I'm constantly working back and forth with what I'm reading to make sure that I'm getting what I need out of the journal. When I open a journal and I look at a new book, I don't start really by reading every word. I sort of go straight to a few things, right? I go to the title and I look at the abstract and I say, what is the main sort of question they're asking here? How many patients? Then I kind of look at the methods. How many patients did they study? For how long did they study them? What were the outcomes? What were the results that they were looking for? And then finally, sort of what was the conclusion and is it applicable to me in the real world? So for me, I'm always saying, does this matter for my hip or knee patients in the real world? Because some of it is absolutely just research. What do I mark up? Well, let's take the journal here. The Journal of Arthroplasty, October 2025. And you can see a month old. And so the first part of it is just obviously a table of contents, all the articles. And then there's usually sort of an editorial or two. And so I like to read this. This one, Physician Payment Reform in Orthopedic Surgery, Balancing Cost, Quality, and Access, right? So obviously I'm interested in this because I'm a physician and we get paid in orthopedic surgery. And so they have a few things here outlined. You can see 1, 2, 3, 4, 5. And then I'll sort of write myself a note at the end of this. So I read this editorial and my note is, none of these measures account for the value given to the patient. Reform, 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 all they say, and it never works. Ask the patient for the value. Otherwise, close your shop and do something else. To me, I'm a little bit of a, naysayer sometimes, right? A truth teller, if you want, when I read these things. But here's some other stuff. Global outreach, a case for arthroplasty, right? So this is an editorial of us justifying our need of why we are important for the world, right? Here's one, to bend, to not to bend. Obviously, the first few articles in this particular journal are about arthrofibrosis or stiffness. And so you'll see I kind of have some stiffness and nothing really new from the editorial, but you'll see as we open up a new article, we kind of have another article. And so this is kind of what I would do. Read the article, figure out where it's from, and then I'll look at the abstract. What's the background? Obviously, I can get the background from the title of the article. I'll look at the methods, the results, and the conclusions. And from there, I've already sort of started my notes. So you can see in here, age, tobacco, African American, ASA, which is an anesthesia class and prior surgery. Those are higher risk for having this knee manipulation or getting stiff. Interestingly enough, not diabetes, which is sort of a risk factor for everything else. And so then I'll kind of read through and then I'll sort of look through the data a little bit. Again, I don't know if this is the right way of doing things. It's how I do it. I'll always sort of search how many articles did they look through in this particular type of study. And then I'll kind of sort of look at the outcomes. And so you can see here, one thing that's interesting to me, 3.6% of patients got MUAs. I usually tell my patients it's normal about 5 to 8% of the time. And then here's the results. These are the risk factors, and with the sort of the p-values, if you will, which p-values are statistically significant, which is just a nice fancy term for did it make a difference if they had this or not. And so I'll go through that and I'll kind of briefly look through these lists of articles. This is the list of articles. And then we'll finally get to a discussion. And so they'll start to discuss their results and their findings and sort of relate that back to previous articles, things like this. And so I've written myself a couple notes. I circle younger patients and I say, define for me younger, right? Because they never really defined it. What is that patient population? And then they say here, talking about knee surgery and previous surgery, and even a primary knee as being a source for stiffness. And I say, well, why does revision total knees work? It's a repeat surgery, but I know that it works. I've been doing this for 25 years. So I'm just asking myself these questions as I'm reading it. Here, kind of a little more data, then kind of the conclusion here. It says here, socioeconomic differences, which could lead to decreases in access to physical therapy. So they're talking about why somebody would get stiff after that. Well, I don't know that that's really fair to say that, in my opinion, because I kind of sometimes believe that it's a biological thing, not just a socioeconomic thing. Talk about ways to treat it, which are interesting things that I already do, talking about giving anti-inflammatories and steroids. And then they have this thing that says they suggest revision surgery could further increase the need for manipulation under anesthesia. Well, I can tell you I've been doing this for 25 years, and I know that revision surgery will work and improve patients' range of motion. So I'm not sure why they can say that, not in my experience. Right? And so then I get to the end, and so I have a little note here. It identifies high-risk groups. We'll still operate on these individuals. In other words, yes, these patients might have a higher risk, but guess what? We're going to roll the dice. I even say that. We'll roll the dice. And then if they get stiff, guess what? We're going to treat them. And thank goodness we have opportunities for treatment of these particular patients if they become inflicted or stiff. So for me, it doesn't change me, this article. It's an interesting article, but it's not going to change how I particular practice, right? So that's how I'll do it. And I'll kind of race through the articles, and you can see I just have an active pen everywhere we go, right? Always looking for the statistically significant and always answering the question, does this make me a better surgeon? At the end of the day, I have a Monday morning test. At the end of each article, I ask one simple thing. Does this change what I do on Monday when I'm seeing patients? And if the answer is yes, I'll adjust something. Maybe patient selection, maybe an implant, maybe a specific rehab protocol. I don't know. But if the answer is no, and it's interesting, it goes into that sort of that good to know pile upstairs in my brain. The context will help me sort of counsel patients. And for whatever reason, I like sort of memorizing some of this stuff. So, this is what it looks like when you stack things up over years and years, right? You're just learning. None of me and how I read these articles is about being right or reading it the correct way. I have no idea if I read the orthopedic journals in the correct way. In other words, would they pass an academic purity test? But that's how I do it. It's early, it's focused, it's pen in hand, and I'm always asking, does this help me take better care of you? So I'm not sure if you're interested in that, but in my concierge model, you're not just paying for the hour in the operating room. You're getting all this stuff behind the scenes, the years of borderline obsession with hip and knee replacement, constantly updating what I know, constantly stress testing whether the new trend is actually better or if it's just louder. I'm not trying to be a generalist. I'm not trying to learn about every body part. I picked hips and knees on purpose, and I've spent my career going deep on just those two joints. So when you walk into my office, you're walking into that stack of journals too. All those hours spent on quiet mornings learning more and more than I possibly can. And honestly, I wouldn't have it any other way. So if you want more on hip and knee replacement, literature stuff, recovery, costs, real patient stories, check out the playlist below. And if you're trying to figure out what your own next step is, start with the joint quiz or contact page in the description below. That's the best place to get connected with me and my team. If this helped, like, share, and subscribe for more straight answers about hip and knee replacement.